Hello, I'm hematologist-oncologist Dr. Tony Talebi. Today we're going to discuss estrogen receptor-positive breast cancer. I have the pleasure of being with Dr. Mark Libman, Chairman of Medicine at University of Miami. Previous to that, he was at the NCI for a number of years, as well as Chairman at the University of Michigan and Georgetown. And he truly is a giant in the field of breast cancer. So it's an honor for me to be able to speak with him. Thank you so much for being here.
My pleasure.
Dr. Libman, what is estrogen receptor-positive breast cancer?
So, normal breast tissue responds to the female sex hormone estrogens. At puberty, a girl has breast development because estrogens change in her body and her breast responds to those estrogens. The way it does so is that there is a protein in the breast called the estrogen receptor, and the estrogens bind to that receptor protein and initiate a cascade of events that eventually result in growth. Breast cancers remember that property much of the time, and when they have the estrogen receptor, it is common that the breast cancers will respond to estrogens by growth.
You were actually instrumental in the discovery that breast cancers grow in response to estrogen. How did that come about?
I had originally been doing some work on leukemias and had been able to show that the glucocorticoid receptor, a receptor for cortisone-like hormones, was critical in determining whether they would respond to those hormones. It occurred to me that perhaps I could do a similar kind of discovery in breast cancer, and we were able to establish human breast cancers that would grow outside of a woman's body, demonstrate that they had estrogen receptors, and show that they would respond to estrogens by growing and be inhibited by anti-estrogens. And that led to a series of discoveries in many laboratories that have been able to substantially alter endocrine therapy for women with breast cancer.
That's truly fascinating. That's great. What is the difference between a ductal tumor and a lobular tumor?
In order to understand that, you need to know a little bit about breast anatomy. Think of a tree turned upside down, stuck in the ground, with the stump coming up. Think of that stump coming up through the ground as the nipple. The leaves are the equivalent of lobules, areas where milk is made. And then that milk is connected in these branches as they come to the roots and deliver milk for a baby. Breast cancers that arise in those leaves or lobules are called lobular cancers. Breast cancers that arise in the ducts, those little tiny branches, are called duct cell cancers. The difference is probably not that important. It used to be considered very important, but there are many other properties that are more important. Knowing what country you came from is probably going to tell me less about what kind of doctor you are than other things that I could know about you.
I see. So what is important then as far as breast cancer?
Well, there are many features that are critical, that are traditional. The size of the tumor, whether it has spread to lymph nodes, whether it's estrogen receptor positive or not, whether it has new other properties, molecular properties that allow us to use these new biological therapies. All of those are quite important. And to some extent, the woman's status as well, what kind of medical state she's in.
I see. What are some risk factors that predispose a man or a woman to develop breast cancer?
90% of all breast cancer is, in some sense, caused by estrogens, whether normally produced by a woman or hormones that she takes. 90% of all the difference in breast cancer in the world is explainable by how long a woman is exposed to estrogens. When her period started, when she had her first full-term pregnancy, when she had her menopause, whether or not she took post-menopausal estrogens. In addition, certain physiologic features that determine how much estrogen there is in a woman's body, how tall she is, whether she's overweight, control estrogen in a woman's body. Men have the same risk factors in terms of estrogen production. Men who take estrogens at the same concentrations that women do have the same risk of breast cancer as women. Other critical risk factors are genetics, which we'll get to in a bit. Alcohol ingestion. It turns out, perhaps unfortunately, that even a couple of drinks a day, not necessarily a great deal of alcohol consumption, significantly increases breast cancer risk. And exogenous radiation. I don't mean a chest x-ray, but serious radiation administered for a variety of reasons can dramatically increase breast cancer risk.
When is it appropriate for a patient to seek genetic counseling when they've been diagnosed with breast cancer?
In general, any woman, in my view, who has a first-degree relative with breast or ovarian cancer, meaning mother, daughter, son, or sister, ought to be screened genetically. There are somewhat more nuanced rules about this, but that's close enough. There are certain other groups who are particularly predisposed to genetic causes of breast cancer. And, for example, for any woman under the age of 50 who is of Ashkenazi Jewish heritage, even if she has no family history known to her, I think it would be well advised to screen such patients. There's actually beginning to be evidence to suggest that if you look at patients under 50 with triple-negative breast cancers, you will detect a fair number of patients carrying genetic predisposition.
I see. When is it appropriate for the family members to have screening mammograms when a patient's been diagnosed with breast cancer?
If a woman has a first-degree relative with breast cancer or ovarian cancer, I think she should begin her screening at age 40.
I see. There's a whole new classification of breast cancer based on genetic profiling, such as luminal A, luminal B. Would you please explain to our patients what that means?
This is one of the most exciting developments in breast cancer. Up until recently, we described or defined all cancers mostly by city of origin. Prostate cancer from the prostate, lung cancer from the lung, breast cancer from the breast. And as I mentioned a moment ago, that's in some ways about as useful as saying, my parents grew up in Russia. Does that define me in any particular? A little bit, but not much. We now know that if you look at many different genes in a breast cancer, they fall into 5 or 6 patterns. And these patterns really do define the behaviors of the breast cancer. Luminal A is one kind, luminal B is another. So-called triple negatives or basal cell cancers are a third. So-called HER2 positive breast cancers is a fourth. Claudin low is another. And each of these kinds of breast cancers, which can now be told apart, has different treatments, has somewhat different behavior, and it's a very useful classification, which will undoubtedly become even more defined and detailed over the next few years.
I see. So let's just take a step back. Let's assume a woman or a man has had a biopsy of a breast mass which has come back positive for breast cancer. We'll get to the details in a minute, but generally speaking, what will happen next for that patient?
Well, it's a little bit tricky. There are a lot of possibilities based on that question, but usually once one has had a diagnosis of breast cancer treatment falls into several separable categories. The local treatment of the tumor within the breast to assure a low likelihood of recurrence and a high likelihood of control and the best possible cosmetic result. Commonly, most women can and should be managed by lumpectomy, which is exactly what it is, sounds like, and then the rest of the breast can be treated with radiation. But sometimes that's not the right treatment, and occasionally mastectomies are indicated. The second part of treatment is to deal with the possibility that breast cancer cells have escaped from the breast and spread distantly. A woman may say, I had breast cancer, now I have bone cancer. And what she most commonly means is that she has breast cancer that has spread to the bone, what we call metastases. The single biggest advance in the treatment of breast cancer, the most revolutionary advance, is our certain knowledge that if we treat women with treatments that get into their bloodstream, that can go to every nook and cranny of their body, shortly after their primary diagnosis of breast cancer, something called adjuvant therapy, we can most dramatically improve the survival for the disease. When I first trained in breast cancer, not that many years ago, 50% of all women diagnosed with breast cancer died of that disease. Because of these systemic treatments, that number is about 17% now. That's a dramatic improvement. Not perfect, but a huge advance.
What does the term staging mean?
Staging means that you come to an agreement based on guidelines that have been published as to how advanced the disease is. There's clinical staging, that which you can do with your hands and x-rays, and there's pathologic staging, which means that the pathologist actually looks and says, I see something. And there are 4 stages for breast cancer, actually 5 if you include stage 0, which is non-invasive breast cancer. And each of those stages has a different prognosis and a somewhat different treatment. But virtually all patients can have some chance of cure. And even these days, an occasional stage 4 patient can have 20 to 25 years of survival. And if you're 55 or 60 when your treatment starts, that's about the same thing.
I see. Should one's diet change once they've been diagnosed with breast cancer?
There are certain data, absolutely certain, that maintaining a normal body weight and exercising can reduce the risk of recurrences. So everything that one can do to encourage someone to maintain or lose weight to get to a normal weight is seriously important. There are lots of reasons why people drink socially, and certainly drinking socially reduces heart disease, but there's evidence that discontinuing alcohol also reduces the risk of recurrence as well.
I see. What are your thoughts regarding hormone replacement therapy in breast cancer?
So, hormone replacement therapy, what women take after menopause to alleviate symptoms, comes in 2 flavors. One flavor is estrogen alone, which we will call estrogen replacement therapy, and one flavor is estrogens plus progestins, which we will call hormone replacement therapy. Hormone replacement therapy causes breast cancer, period. 5 or 6 years of hormone replacement therapy will double a woman's risk of breast cancer and will increase the likelihood that she will die of it. So in my view, hormone replacement therapy, that is estrogens plus progestins, for more than a few months has no place whatsoever in the management of any woman that I can imagine a scenario for. Estrogen replacement therapy, for reasons that are not fully understood, is a horse of a very different color. And the risks associated with estrogen replacement therapy are almost non-existent for the breast. Part of that is because most forms of estrogen replacement therapy are only about a 25% replacement dose. It's for what the body would be making normally. And there may well be some ancillary gains in terms of reduced colon cancer, and there's certainly decreased risk in some settings, as has been demonstrated for cardiovascular disease. So estrogen replacement therapy is something that can be considered, particularly for limited periods of time, but hormone replacement therapy, as it used to be given with estrogens plus progestins, is very ill-advised.
I see. Well, thank you so much. Thank you for watching. We hope this has been educational for you.
Okay.